One of the stories coming out of Toronto this week is City Council officially calling on Ontario health officials to start collecting province-wide data on COVID-19, race-based data, looking at socioeconomic factors. It is one of the city councillors, Joe Cressy, who's really chairing the city's Board of Health, behind this. And this is one thing he said in a statement. The old adage of what gets measured gets done is especially relevant right now. In order to tackle COVID-19, we must fully understand it and who is most at risk. It brings together our two stories, and we'll do that in a conversation with Dr. Samir Gupta, who's with us every Wednesday, and respirologist in Toronto and an associate professor in the Department of Medicine at the University of Toronto. Thanks for coming back, as we always look forward to your visits on Wednesday, Dr. Gupta, and for bringing these two stories together. I know this has been on your mind.
Yeah, I think this is on everyone's mind. It's just the images are just seared into my mind, and from the point of view of, it's just so sad what we're seeing south of the border, and there's a lot of introspection on, how much of this is happening in our country too. I think that most of us feel like we're not immune to it. We really need to think about, as a society, how well we've done to address this issue here as well, but also then thinking about it from a health point of view.
Exactly. Why don't we do this? This whole notion of COVID-19 and the data that would look at race-based determinants. I heard one doctor put it, you have to collect the data to do good medicine. What are you thinking about whether it's the appropriate thing to do?
Yeah, I think, initially there were some restrictions, and there have always been some restrictions on the type of data we can collect for research studies. Out of concerns that racial stereotypes would be perpetuated by those kinds of approaches to data collection and data presentation. We do have important data from the United States, however, that already shows important disparities, both in terms of Black Americans getting this virus more, but also Black Americans dying from this virus more. In fact, at a rate of 3.5 times the rate of white Americans. So clearly there are racial disparities in this disease, like in many other diseases. In Canada, we don't have that. We don't drill down to that level of detail. What we have mostly are geographic data. So we can understand by postal code which postal code areas are seeing more COVID-19. And we do know, for example, in the Greater Toronto area, that postal code areas associated with a higher density of Black Canadians, racialized minority, marginalized Canadians are certainly getting this virus disproportionately. So we have some sense of that from Canada, but we don't have the detailed measurement that you're talking about that we need to have to really understand the extent of the disparity and where that disparity is coming from.
So hold that thought, because I want to come back to something. But you're quite right. I mean, there have been a lot of numbers that I've seen, but Chicago was one that I was just looking at this morning. Black people make up 30% of the population of Chicago, but make up more than 70% of the COVID-19 related deaths. So it's not quite as high a number as you're suggesting, but that's just one city pointing to the trending that they know about in the United States. So what then is it, once you have those numbers, what do you do with them that can make for better medicine?
I think the first thing to point out is that, some people are talking about biological differences. That's really not what this is about. This is about what we call the social determinants of health. Marginalized population, Black Canadians, Black Americans are more likely to work in blue-collar jobs. They're more likely to work in the kinds of jobs where you don't have the luxury of staying home. Many of the measures that we've recommended are measures that are really difficult for folks who don't have high income levels. They don't necessarily have the internet connections and the computers to do Zoom calls. They work in service industry. They can't drive to work. They have to take public transit to work. They're much more likely to be exposed to this virus. So one part of this is getting the virus. The other part of it is once they have the virus, why are they being disproportionately affected in terms of how sick they're getting and how often they're dying, at least in the US. Over there, that has to do with access to healthcare. We know that it's not an even playing field with respect to access to healthcare resources. But even here, I'm certain that we would see some of those disparities because it goes beyond access. It goes to the attitudes of everyone in the healthcare system That goes from health administrators all the way down to doctors, and we're all complicit in this.
So we're going to bring in some pictures of something that happened yesterday in one of those postal codes that you mentioned that has been highlighted as being a hotspot in the Toronto area. And if we have pictures to show, what happened there yesterday was, for the first time, they sent out to that particular geographic part of the city a mobile testing facility. And people were lined up. It was a tremendous response to this. So does this illustrate exactly what you're talking about in terms of, if you know where to look, you can respond with the appropriate measures?
Absolutely. Some of these measures, it's more challenging often to overcome these kind of social disparities that lead to inequities in health. But some of these issues have to do with access. And so if folks in these parts of the city and parts of the country don't have access to testing centers, can't get to testing centers, you bring the tests to them. Some of it is education, some of it is direct access, mobile testing, but then also mobile health care. So there are many different things that are going to need to happen to try to iron out some of these disparities. It'll be really challenging to do. But as you say, first we need to measure and understand what they are and get some sense of why these things exist in order to tailor-make solutions to try to even that playing field.
Dr. Gupta, thank you so much. Appreciate your weighing in on some of our big stories this morning from your eyes. As always, we welcome you on Wednesdays. Dr. Samir Gupta, respirologist and associate professor in the Department of Medicine at the University of Toronto. Thanks again.